Today we will discuss the surgical orthodontics procedures that deal with the structural malocclusion of the maxilla and the mandible. It can starts from an extraction of an impacted 3 molar to full osteotomy of the maxilla or the mandible. Usually, the orthognathic surgery should be delayed until growth is complete in patients who have problems of excess growth. But in patients where they have growth deficiencies, we can perform the surgery in an earlier stage. The first surgical procedure is the exposure of the teeth. The most common teeth to be impacted is the canine. So here we remove the bone above the teeth and expose it. Then we add a bonded bracket and we start the pulling of the teeth. This is another case of a canine surgical expose. Here we used a bondable lingual button and it is attached to the canine. Then an occlusal force is applied using a ligature wire. This is it. Sometimes doing surgery is enough to maintain an optimum results, but in some cases an orthodontic fixed procedure can be done prior or after the surgery to correct any dentoalveolar deficiencies. Also, if the child was in the growing stage, we can use the functional appliances to do growth modifications. What are the steps of doing the surgery? First, we do a pre-surgical photographs, radiographs, and pre-surgical models with a centric relationship that is registered. And we do what is called a mock surgery, where we duplicate a pre-surgical cast to determine the exact surgical movement necessary to achieve the desired occlusion. Now let's see what are the techniques that can be done to treat the mandibular excess. The first one is called the vertical ramus osteotomy. This is it. In this technique, the ramus is sectioned in a vertical line and the entire body of the mandible is moved posteriorly, where an overlap between the segment that contains the condyle is overlapped on the posterior portion of the posterior and side of this, the ramus side here. And the jaw is then stabilized during the healing phase. Another approach is the bilateral sagittal split osteotomy. Here in this technique, we do a bilateral splitting of the ramus and the body of the mandible. In this case, we can do an advancement or a set back of the mandible, which gives us a large area of flexibility. And this overlap will give us adequate bone healing and an improved stability. Another approach is called the mandibular subapical osteotomy. This is it. It is indicated where we have a class 3 anterior overjet of the mandible, and we need a technique to correct the anterior segment. So what we do is to extract a premolar or a molar and remove its associated bone. So we can move the anterior segment posteriorly and correct the reverse bite. These are the techniques to treat a mandible that has an excess growth. What about a mandibular deficiency? How can it be treated? We do what is called the BSSO with mandibular advancement, which means that we do the same thing in this procedure here, but instead of getting the mandible back, we advance it forward. Another approach is called the mandibular total subapical osteotomy. It is indicated in class 2 malocclusion, where the dentoalveolar segment of the mandible is moved anteriorly. This is it, without increasing the chin prominence. Another approach is the vertical L or C osteotomy. This is it. It can be used when large mandibular advancement is needed. Greater than 10 to 15 millimeter of mandibular advancement is needed. It combines the sagittal split and a vertical ramus osteotomy. In this case, we need an iliac crest bone graft to be filled in the osteotomy defect. Here we have. Now, let's talk about how can we correct the maxillary abnormalities. The most common method is the Lefort 1 osteotomy, where we can perform correction in the anterior, posterior, transverse, and vertical plane and get a 3-plane space movement. This is the Lefort 1 osteotomy to correct the maxillary structural deficiencies. And this is Lefort in the vertical axis. Another approach is the anterior maxillary subapical set back. In this procedure, it is used in class 2 malocclusion caused by maxillary excess that is limited to the anterior posterior dimension with no vertical increase of the maxilla. In this procedure, we extract the first premolar and its associated bones, and then we do is to position the anterior segment posteriorly using this extraction space that we got. Another approach is the segmental maxillary osteotomy. This is it. In this case, when we have an excess vertical growth of the maxilla and we have an open bite, in this case we do a bilateral posterior segmental osteotomy, and the first premolar is extracted with its associated bones. So we have two segments, an anterior one that is from the premolar region and a posterior region that reaches the molars behind. So we can do a superior and posterior movement of the maxilla to close the open bite. After a period of healing, we should do a retention for the surgical procedure. Also, some orthodontic movement can be indicated. There is something that is called the cosmetic surgery for the chin, When patients have abnormalities in the chin, where it is too flat or too prominent, so we can do what is called a horizontal cut and move the chin in the desired direction. We must know that doing the conventional osteotomy has several limitations. The first is that the soft tissue cannot adapt to the changes when large skeletal movements are done, and the stretching caused by the surgical reposition may result in a failure of adaptation and result in a relapse. Also, we are doing an excessive loading on the temporomandibular joint. There is a risk of a neurosensory damage. Also, in this approach, we need, in some cases, a bone graft from far places like the iliac crest. So there is another approach that is called the distraction osteogenesis. In this approach, what we do is to separate the segments of the bone, and we apply a traction appliance that will facilitate the gradual and incremental separation of the bone segment, where gradual bony segments are formed. We have what is called a continuous formation of the bone. Also, the surrounding tissue will adapt to the gradual movement, and the muscle and nerves will be more safe in this procedure. Also, there will be no need for any bone graft, and there will be less chances of temporomandibular joint trauma. However, this technique is sensitive and it needs two surgical procedures, the placement and the removal. Also, it takes more time and the cost will be increased. The most important thing that it is only used for skeletal discrepancies with deficiencies. Deficiencies cannot be used for treating excess of the jaw. So it is only a forward movement and cannot do a backward movement of the jaw. That's it.